Hello, everybody. Welcome back to the COA podcast. We are very blessed today to have, as usual, Father Gabriel with us. Welcome,
Paul.
Father. We also have Father Anthony with us. Father.
Good to see you.
Good to see you, too. We always miss you, Father. And today we have a special guest with us. We have Dr. Samuel Fanous from Edmonton, Alberta, in Canada.
Thanks.
He is lovely to have you. He's a palliative care physician, right? And my first question off the top, and I told you I'd probably ask you this, is what were you thinking? That seems like a very tough specialty to have, and one where I don't imagine you have very many up days. So let's start with there, and then we'll tell people what we're here to talk about today.
Fair point. I know that's a common reaction that I get. Everyone will hear the words palliative care. Their mind obviously orients to death and dying and end of life. And they'll say like, oh, it's so depressing. How are you not depressed? Or how are you not like walking around with a cloud over your head and it's raining all the time? But I mean, first and foremost, like the opportunity that I have to do the role that I have in palliative care, it's a gift and it's a grace. And the way it opened up, especially when I moved back home to Edmonton in 2021, that like the timing was God's hand for me to be able to work in palliative care. When I look at my experiences as a med student and my experiences as a resident and doing my fellowship in care of the elderly, the patient experiences, the families, the nursing staff, and the physicians that not just mentored me, but like imprinted on me as a trainee were those within the fields of palliative care and geriatrics and family medicine. And I felt like this is something I thrive in. I'm half decent at it, if you will. I'm not perfect by any means, but I enjoy what I get to do, because while it is, yes, like a vulnerable part in life, to be able to serve in this area, to be able to like help people at this stage is an incredible gift, and given me more blessings than I truly deserve. So I also love the fact that most of my job is doing home visits for patients. So I love that I can see them there and care for them at home, and you get to know people like intimately well. And I think it's nice to experience a very human side to medicine, while albeit, yes, a vulnerable side. But truly, like every year that I've reflected about this, I'm like, I love what I get to do.
I'd imagine that end-of-life care is probably the biggest intersection between spirituality and medicine that exists, because, I mean, that's it. That's where that line is ready, right? So I'm sure that has an effect on you and your faith and everything.
Definitely. It's if it's fair for me to say, like it's helped me see God in a way that I didn't imagine previously, just through the interactions of patients, sometimes the faith that they have, the beauty in the people that I get to work with, the nursing staff that are compassionate, empathetic, they care deeply and sacrifice for others, and I'm witnessing qualities of love in my work regularly, and I'm like, therefore I'm obviously witnessing Christ in those experiences. It's not to say that this work isn't difficult, and there's tough patient cases all the time, but because it's a team-based approach, like I'm a very small piece in the puzzle that does very little, especially in comparison to my nursing staff and others that I get to work with. But it's a beautiful gift to really be able to do this. Well,
we really appreciate you coming with us. It's awesome. So if everyone's wondering what's the subject today, one of the hot topics, especially in Canada and especially in recent months with politics and all that, is MAID, medical assistance in dying. And what better way to talk about it than to bring a specialist in the field? So welcome. But let's start there. Let everyone grasp and maybe introduce palliative care and MAID, and so that we can have an intro to start talking about it.
Sure. Well, since we're kind of diving into the meat of the conversation, I'll say that what I bring today is not a reflection of like any professional organization. There's always going to be a lot of discussion amongst those that work in medicine and healthcare as a whole on some topics, but what I say today is like just not a reflection of those that I work with. But palliative care, it's an area of medicine that cares for people with life-limiting or terminal illnesses. Fancy way of saying they have an illness that they're dying from. It could be a heart problem, could be a lung problem, could be a kidney problem that's end stage, or most often cancer. And so cancer, sadly, as a disease doesn't discriminate. It can affect any part of your body, your skin, your eyes, your liver, your lungs, your kidneys. And it may reach a point in which an illness is not curable. And the goal with palliative care as a team between nursing staff, respiratory therapists, other doctors, healthcare aides, occupational therapists, you name it, it's a holistic approach, along with priests and grief counselors and psychologists. And really at the core too, I should never forget this, is like the family and the loved ones of patients that are around them. As a team, holistically, we're there to support them so they don't suffer physically, don't suffer psychologically, spiritually, financially, even socially, on a journey that leads to death. However much time they have, that's in God's hands. I'm not there to, look at a calendar or, shake a crystal ball and know. The analogy I often use with my patients, I tell them is I will do my best along with my team to calm the storm. And what I mean by that is that like death is a tumultuous journey. It's ups and downs along the way, but I have an influence into how high those peaks and how low those valleys truly are. And alleviating suffering and allowing a person to die with dignity is essentially the goal within palliative care. And it's not always like some people think it's okay, those last short days or weeks before a person dies, that finally this is how you introduce palliative care. But statistically, and what research says is the earlier that you introduce a palliative approach to a person's care to manage symptoms that might arise as a result of a chronic illness that may be incurable at a particular stage, they potentially have a bit more longevity and live longer, but also their quality of life vastly improves by providing these measures and addressing symptoms and concerns earlier than later.
Let me ask you a bit of an ignorant question on my part, but a lot of people always say, the doctors gave me 4 weeks to live or 5 months or 4 minutes or whatever it be. And I always found that not arrogant, but a bit like, on our part, like how can we say that, and how could you even look someone in the eyes and tell them that, So maybe I'm the one that's wrong and I don't understand. Maybe it's based on, calculations to help someone grasp it. So can you just shed some light on that for a little bit?
This comes up a lot. And I think in different spheres of healthcare, and particularly like when with my cancer patients, let's say they're talking with oncologists and cancer specialists. And along the way, they have studies that show evidence that a person with a particular cancer diagnosis, this is the average potential lifespan that they do have with or without chemotherapy. And they use that as a particular guide. However, this is just a reference. And in palliative care, we kind of stay away from definitive language when it comes specifically to time or prognosticating. Because my patients are eventually going to ask me as well, like, doctor, how much time do you think I got left? And there are ways to assess a patient clinically to say like, hey, like, are we in the realm of months potentially? Are we in the realm of weeks? Are we in the realm of days? Does it look like hours? And there are like symptoms and signs, especially at the end of life, to suggest that. But I'm never going to tell them, yes, I'm right and I know what I'm saying. No, like I've been wrong many times when it comes to prognosticating. But people do ask this question because they do, and especially for families, they want to be prepared. Like, okay, when should I make sure I am here? Are there signs and in evaluating patients where we look at how often do changes happen in the person that might suggest, hey, like, is our timeline getting a little bit shorter? And, truly, I think I do carry a bit of a professional responsibility to them when they ask these questions. So, because I don't think it's fair to say just to shrug my shoulders. Like, if I see changes in a patient happening weekly, maybe we are in the realm of short weeks. If there's changes, which, and typically with most of the interactions I have in the trajectory of a person's health, the rate of change in their condition gets quicker over time. Instead of every 2 weeks there's a change, maybe it's weekly changes, and then it starts to be every few days or daily changes and hourly changes when a person's really close to end of life. And we do our best to guide families so that they can try to find some solace and preparedness really for a death.
You have a unique vantage point in that you deal with the finality of death in people. And you deal with their reaction to the finality of death. I think any medical professional is kind of dealing with the opposite, like the hope or how do I cure and all that. But you see, like, you're giving this timeline to someone and they have to accept it. Has that taught you anything about human spirit or about spirituality in general, just to see people finally come to the end and say, like, this is it, For
some people, like, it's different spectrums. Like, I often see people of faith, they have a lot of peace amidst this journey, and truly faith across different domains in medicine, whether it's in a psychiatric sphere or in palliative care. It's a strength and a protective experience for a person. I guess to answer your question, it's different. Some people do like suffer spiritually at the end of life. Some people do struggle with that finality. But for some people, and I think of the words of St. Paul in Ephesians, where he said to like speak the truth in love. And often something I tell a lot of like the trainees that I get or students and residents is like, one of the kindest things that you can do for another human being is speak the truth. Even if it's breaking bad news when there's a tough diagnosis, or even if it's potentially telling them our timeline's getting a bit shorter, or for other specialists where they have to tell them this chemotherapy medication that you're getting for your cancer is no longer working and we don't have another option. Truth is important in this life. I think God reveals himself and he is truth himself, and people witness him in those experiences too. But there's no escaping that death is an experience everyone's going to go through. Nobody can avoid this. And I think the more we talk about it, the more we prepare for it, it allows a potentially beautiful experience at the end of life as a person kind of dies.
I have to tell you, there's something that you said earlier when you talked about the gift that you have in being able to walk with people in that kind of journey. I think we even, as clergymen, we are sometimes put in positions pastorally where one of the greatest gifts we can have is to be able to accompany people as they go through the mystery of approaching death. And the mystery of life and death is really interesting, especially when you're a person of faith, because we also witness miracles in those last days. We see people who have complete conversions at the level of their heart. Reconciliation that has been like so much conflict for decades, and now there's reconciliation. Life confessions while people are in hospital beds. People receiving the Eucharist when for decades they had refused to. We also see sometimes the opposite. People who till the very last breath they're rejecting and they're stubborn. But there is something about this mystery of life and death that is revealed in those moments where we have such an incredible opportunity as human beings, as family members, as part of the community of the church, or even as medical professionals who also believe in the power of the spirituality of the church. We have so much positive influence to be able to bring forth to a person who's dying.
Forgive me, Father, and usually I'm supposed to be the clown that, like, brings light in these situations, but for the depressing scenario where people are struggling, have more fear in death, more stubbornness, and this is a question for all three of you, actually. You on the spiritual side, but Dr. Sam, you also on the physician side. How do you deal with the frustration of knowing your faith and seeing someone's time clicking away? Just tick tock, and you're like, that's it. You have moments. Why are you being stubborn? Like, you have nothing to lose now. Just accept. Isn't that like how do you even deal with that? This is a tough one, so whoever wants to go first.
I mean, it's definitely very difficult, and it's very saddening. And it's unfortunately a reality, right? And I think, to me, the biggest message I take from this is that it's a reminder that not everybody ends up being the right-hand thief on the cross. So sometimes the right-hand thief, becomes our, ideal, way of life, so to speak, that I can sin, do whatever type of thing. And then at the end of my life, I can resurrect. And this doesn't happen most of the time, because the more you sin, the more your heart is hardened, and the more difficult it is for you to repent. So sin is not a joke. So for us to avoid sin and live a righteous life, and having this moment of death in our minds daily, like the Desert Fathers have taught us, is quite important. So, but to your point, it is very saddening. We do what we can. We pray for them. We hope for the best. But at the end of the day, everybody has their own free will. And we continue to pray for them, and may God have mercy on them. That's all I can say.
If I can add.
Yeah, so I was going to ask you, how do you deal with that? You have the professional side, and then you have the spiritual side.
Yeah, it's and it piggybacks off what Abuna just said, and understanding like free will. Free will in and of itself is an incredible gift. And in this experience with palliative care, especially when it comes to contentious topics around medical assistance in dying or euthanasia, free will. It's God gave us this for a particular reason, to choose him, and it gives value to our decisions in this life. Nothing of what we do would have value to you as a human being if you couldn't make choice. And we have to respect, there's a perfect moral judge, a perfect moral being in this life, and God himself, the perfect arbiter, who will give us that clarity as far as what is positive or net positive in terms of your decisions, or potentially negative. But in this field and sphere of palliative care, and I think when it comes to this end of life experience and the choices that people make, like even when there's circumstances of a patient is refusing pain medications, and they want, and the desire is, this pain is of value to me. I make this decision because this pain brings me something, whether it's a spiritual or existential experience that they desire. They have the right to refuse if they want to, if they're of sound mind, of course, and able to do that. But choice in and of itself is a beautiful thing. And I think it's important, and especially going on in this conversation too, like, hey, like, let's respect the fact that people have choice. And,
So take me now to MAID in Canada here.
Yeah.
Not made in Canada, as maple syrup, but like
Nice.
medical assistance. You see what I did there?
Yeah.
Medical assistance in dying, the way we practice it here.
Yeah.
Take me through that evolution, because you hear more and more. So what's gone wrong or right, or what's happening? That's
I mean, it got legalized in 2016. We've seen the rates and numbers grow up immensely, especially since 2021. Here, Quebec and Ontario kind of lead the country in terms of like the proportion of provisions. Largely, yes, you have a larger population, but there are a number of provisions here. And even when I hear from some of the practitioners who provide MAID, they'll look towards Quebec when it comes to novel ideas and things that they might be adapting as far as medical assistance in dying goes. By definition, kind of what it is, it's an action that rushes towards death. A patient, first off, has to give consent. And here in Canada, you have to be over the age of 18, and there's kind of like two tracks. They call it track 1 and track 2 for those that can have the MAID provision. Track 1 is those with what we call a reasonably foreseeable natural death. They have an illness that they're dying from: cancer, end-stage heart failure, end-stage COPD, pulmonary fibrosis, ALS, illnesses that you're going to die from this at some point, qualifies as track 1. What we see in track 2, and what's kind of evolved in the recent years, is those that aren't necessarily living with an illness that has a reasonably foreseeable natural death, meaning an illness that's not necessarily going to end their life or kill the person. For example, somebody who's living with rheumatoid arthritis, an immune disease where it causes joint inflammation. There are often a lot of good regimens and treatments and things that can keep it at bay or stable. But yes, a person lives with pain, and this illness may be something they live with for the rest of their life. Are they going to die immediately from rheumatoid arthritis? No. It's not going to be an illness that ends your life.
Are you serious?
Yeah. Yeah. And this is what qualifies as far as track 2. And a large proportion of those patients, chronic pain is often a reported symptom.
And this is one of the developments historically. It started off as something, and then this was added on.
This was added, yes.
So
it's always the case, right?
Time out.
Yeah, I said a lot, so I apologize. Yeah, we have a lot to go
Time
through.
out before I even get to track 2, which I don't. Is that actually legal? Like, I can't even believe that's a thing.
Yes.
Okay, so let's put track 2 on the side, because track 1 for a second here.
Yeah.
Does that even have like a timeline? Like, what if it's the beginning of a disease that could take 30 years to progress? Like, is there any?
I mean, this is where you hope, like the judgment of the physicians is important here. If a patient is in that particular circumstance, they might fit into the track 2 panel. And one of the requirements for track 2 patients is that the assessors, which there has to be 2 assessors on 2 separate occasions that come and qualify if this person, 1, is of sound mind to make the decision, and 2, understands what they want with respect to MAID in order to end their life. But one of those physicians has to be a specific specialist in that area in order to evaluate the patient. And they have this thing where it's like a time period after a person, let's say, has their assessment, for which they can then decide when they want to proceed. And with track 2 patients, it's listed as 90 days. However, and like track 1 patients, they got rid of this specific requirement of a waiting period. Like you could be assessed morning, have your MAID assessment number 1 in the morning, MAID assessment number 2 in the afternoon, and proceed with MAID later that day if you really wanted to, or the next day. Track 2 patients, they do have this clause where if a physician is worried a person is going to lose capacity, they could move up their timeline with respect to this 90-day period for track 2 patients who don't have a reasonably foreseeable natural death, in order to proceed at an earlier timeline if they wish. So yeah, like over these recent years, maybe this is a point that you're going to get to in a bit, but I don't want to like jump the gun.
No, please, just I have too many discombobulated questions.
Yeah.
You might as well just go and then I'll,
Yeah, like it's, like I started this work in 2021 and each year I kind of reflected on, okay, what's happening with my career and where is like MAID really at? And truly, like in the first few years, I was failing in my responsibility on this specific issue of medical assistance in dying. And I don't mean that in a sense of a professional responsibility. I mean that in the sense of like my responsibility as a human being to God above with this particular window that's in front of me. So like in my first year of practice, I feel like I was hearing about MAID from my patients, once or a couple of times a month, or hearing about a patient proceeding with MAID about that same frequency. 2022 rolls around and I noticed like the frequency of these conversations is more. And Alberta, yes, it has less MAID provisions relative to Quebec and Ontario, but still like the frequency is increasing. And then 2023 rolls around and albeit maybe I woke up and kind of realized what was happening, but I realized like a window of opportunity was passing me by because I'd be, let's say I'm getting a patient that's being referred to me for me to take them on my panel, and a person that I'll see in their own home and care for them longitudinally at home. And from that first home visit, they're telling me, by the way, doc, I've completed my assessments for MAID and I just have it as a back pocket option for myself, either when the going gets tough or if my suffering gets beyond what I feel is what I can handle. And I'll proceed if I desire to proceed. What really shook me was, one, the opportunity to even just engage in the conversation when a person is either contemplative or pre-contemplative on this particular idea was passing me by. And I was like very naive and ignorant to what was happening in front of me those years prior. And I had to like reevaluate or recheck like what's my responsibility here as far as just engaging in the conversation at least, because
but at that point, you're handing them a gun with a bullet and saying, when it gets tough, maybe pull the trigger. Like, how could you be of sound mind?
Oh no, I think it's significantly worse.
Yeah.
It's asking the hospital to provide both the gun and for the hospital to pull the trigger. It's very, for the sake of the audience who might not know.
Yes.
Can we maybe just clarify, is MAID the same thing as euthanasia? And ultimately, is it basically giving permission for someone to kill me?
Well, MAID, and largely how it's practiced here in Canada, when a person gives consent, is the physician or nurse practitioner is the one that administers the medications to end the life of the patient. There are other circumstances historically with euthanasia where a person could take the pill themselves and make that choice. And I guess the language and the terminology around medical assistance in dying has largely changed over the years, and in a really concerning way which we'll get to. And I'll kind of explain why I think it's a complete lie in using language like this. But euthanasia, when a person gives consent, the physician typically administers, from what I've read, and not that I've ever observed it or been in the room when it even happens, 3 medications. The first 2 are essentially sedatives to put the patient to sleep. The third medication is given in such a high dose that it will stop the heart of the patient right then and there. Not waiting for them to like, okay, they're very close to death, their heart might stop. No. They could have however much time they have left, and I've intentionally, or the person who's administering has intentionally administered a medication to end the life of the patient at that point.
So the medication that is administered is intentionally lethal?
Yes, intentionally to end the life and stop the heart, and it is lethal, yes.
Can you just for a second explain to me how we got here? Like, how did that become something normal or even legal? What's the government thinking? What's the other side of the argument? Just so that we can kind of comprehend what's happening.
So I think when you look at it historically, there's been mention from like philosophers, Socrates, Aristotle, about this idea of being able to end the life of a person because of their physical suffering. The formalization of this idea around euthanasia, or ending the life of a patient right then and there, or prematurely, if you will, began in the early 20th century. And physicians, eventually being involved in the process, felt that they could give lethal doses of medications, different medications of what's available to us now, in order to end the life of a person because of their suffering, whether that be like a deep physical suffering, usually. And over that span of time, we've seen this idea have a lot of different names. And this is sort of where my first like red flag came up about like this thing is not actually what it is. When you consider it was previously, or it's been called euthanasia, across the board called euthanasia. And I give full credit to Father Anthony Murad because I learned this explanation from him in the past. But when you dissect through the term euthanasia, the prefix EU comes from the Greek meaning good. Euthanasia comes from the Greek thanatos meaning death. So here the world is attempting to define what is a good death. Then we historically moved on and we've seen the terminology of medically assisted suicide or voluntary medically assisted suicide or physician assisted suicide. But people were concerned about the term suicide and wanted, and if you read on certain websites that have to do with MAID, like they said, we need to reserve the term suicide for those with mental health or illness or those with hopelessness. Which is, again, we're going to touch on hopelessness because it still comes up in this sphere a bit. But now we have this new name, medical assistance in dying. And like, let's just telescope out for a second and just take these words like at face value. And for me as a physician, and my bias is obviously going to show, but this name offends me as a physician who works in palliative care because these words, medical assistance in dying, it's nonsense to say this. Let's consider healthcare as a whole. Whether you're a nurse, you're a respiratory therapist, a physician, a pharmacist, whatever your occupational therapist, physio, whatever your role is, in some way, shape, or form, you're providing medical care for people. And the care that you provide varies based on your role. Fair. Yeah. Now, let's layer on top of this the reality of the patients that we care for in palliative care. They're individuals that are dying of an illness. So my responsibility, along with those that I get to work with, is to provide medical care for individuals who are dying. Now I have this thing called medical assistance in dying. And the name is very, the adjectives that come to mind, it is elusive, enigmatic. And even when I consider how it's come up and like referencing what you brought up, it's like, how did this thing even come to be? Just sort of, it was swept under the rug for a little while and now it's up right in front of you. And how it's evolved is very like almost anonymous in the beginning and very gray and elusive. And that's how I see this name embodying qualities like this. And I ask myself, like, why is it that somebody's trying to pull the wool over our eyes of something that's seemingly very sinister, but appearing very dark? Sorry, very innocent from the outside, but sinister from the inside. And when we consider what Christ said, and I know he's referencing like false teachers or false prophets, when he said, beware of those dressed as sheep, but come at you as ravenous wolves. Yeah. An analogy that we commonly hear in day to day is a wolf in sheep's clothing. And I see this very real about what this idea is, that it is a wolf in sheep's clothing. And I don't want to go on too much of a tangent and talk too long because where this idea is coming up, and yes, it's evolving in different track 2 right now, but like in track 1, death and the journey towards death is, in my opinion, one of the 2 most vulnerable periods, guaranteed most vulnerable periods in a person's life. And you're bringing up the idea of rush towards death at a period that is guaranteed to be most vulnerable. And the other only guaranteed period in a person's life in which you are most vulnerable is conception and birth. So I find myself asking this question. It's really interesting that society as a whole says rush towards death at 2 periods when a person is guaranteed to be most vulnerable. And obviously this topic isn't around abortion, but those rates have been high for a long period of time. But human vulnerability is something that I've kind of considered in this particular sphere quite a bit. But
you alluded to the why. What is why? Like, what is the answer to the why from the other side?
The other side is saying, and even when you hear a website being called dying with dignity, the idea is dignity. The idea is you can take control of what you're experiencing to get rid of suffering in order to die with dignity.
But who defines suffering as not a...
Can I ask a couple of questions?
Yes.
Go. So is it fair to say that MAID is used more in Canada than in other countries?
I think proportionally, there was a stat in 2023 saying Canada's per capita rates of MAID have been like within the top 3 in the world since that time. So the rate per capita has increased. But parts of Europe have been doing this for quite a while. In the States, it's not like legalized, but there are pockets of experiences in different states depending on their legislations that would consider something like this. But yeah, Canada's been a forefront for these recent years where they've been advocating for a push to do and provide medical assistance in dying.
We were just talking about this. We were just saying how in Quebec, the province that we are in right now, record-breaking numbers. Almost 8% of all recorded deaths were medical assistance in dying.
8%?
That's almost 1 in 10 people who have died in Quebec were, I'm going to just say it how it is, they were killed by the institution.
Yeah.
That can't be a real number. 1 in 8?
Almost 8%.
8%, so almost
So
1 in
let
10.
me ask, and
Almost
this
1 in
is conjecture, you know, to a certain degree, but it's still, I think, a valid question, because in the way healthcare is done in Canada, right? It's you know, it's free, but definitely not the best. You go to every hospital, there's missing beds all over the place. You're rushed out of the hospital, even if you're not doing well. That happens often enough, and you get sick and you have to go back. So people think that, you know, healthcare here is great. It's not great. In the province of Quebec, it's definitely not.
You're making all the Americans
could there be a link between this? Like, could there be a link somehow where, again, you're talking about like wolves, you know, dressed as sheep, and talking about, like, you know, dying with dignity. But from experience, you know, from different subjects, you know, I arrived at the conclusion that government does not really care about my life, essentially, you know. They might pretend, but they don't really. Is there something on there, or is just my mind going crazy?
It'd be tough for me to say any like definitive statement on
yeah,
this.
of course,
as far
nothing
as,
definitive.
like what's happening or why the numbers are increasing, like 20 to 30% increase year by year.
20 to 30% increase.
Yeah, I think we've seen since 2021, in 2021 to 2022, the number of MAID provisions increased by about like 20 to 30%. Same thing from 22 to 23. We're still waiting on I'm still waiting at least on the 2024 data.
Forget that angle, because I know that also paints you in a rough spot. But whether we think it's a conspiracy theory or real, or that, you know, they're trying to free up beds, which seems to be the logical, you know, that the government doesn't want to spend so much. What's the easiest way? An injection, goodbye, and didn't cost me anything. But, you know, so we can say that. I mean, it's might be reckless or difficult for a physician to say that, but can you then maybe look to the why from the patient's point of view? The patients that you go to their home and they tell you, I have this in my back pocket. What's driving this? Is it the fear of pain, the fear of suffering?
Yeah.
So before you go there, though,
yes.
There's something that, Father, you said that I think is really important for us to mention right here, right now, because the conversation that we're having is also spiritual. I think, Father, you would agree with me that even though there might not be any evidence for an institutional sort of conspiracy, we do know that the ruler of this world is coming and he has nothing in Christ. And because the world is all about its number one marketing ploy for anything that is sold at the consumer level, it is comfort, and at the level of you avoiding any form of suffering, and intentionally trying to facilitate your life so that everything is more convenient. So why not even sell the idea of death at the level of dignity? There is nothing dignified in asking someone to end your life. Now here's the parallel that I would love for the audience to consider for just a second. If we did the exact same thing, completely consensually, I asked my wife to give me a lethal dose of a medication that will kill me, she will be charged with homicide. But because it's done under the care of a physician who, I'm assuming at some point, the Hippocratic Oath meant something. I'm not entirely sure where the Hippocratic Oath fits into this now, where the whole purpose of the medical field is to be able to pursue the restoration of health for the sake of giving life. And yet now, here we are facilitating death. There's got to be a dollar amount behind this. There's got to be a spiritual component to this, where the devil is very happy that there is no such thing as sacredness of life. There's only dignity in death. That's insane.
Well, the fundamental pillar, especially in Christianity, is hope. If you've become so hopeless to take your own life, well, is this not the same sin of Judas, right? You know, like, essentially the devil is smiling ear to ear. You know, I can put you in a spot where you think that this is dignity, but really what I've accomplished here is I've removed all hope. Right? And you always do this, but you take my thunder, because I was going to take us to the spiritual, which is very important. We got to go back to it, because I don't think we covered it enough. But before we go back to it, I just, if that question
about reasons,
the reason that the patients themselves come to you, what's the driving force there?
Yeah. So I'll actually, I have the chart in front of me just because I wanted to reference it, but these are the reasons, the top 3 reasons of what people see as a reason for wanting to proceed with MAID. So loss of ability to engage in meaningful activities, and how that looks, of course, varies person to person based on their life and what they live. Loss of ability to perform activities of daily living, and activities of daily living is categorized in kind of 2 things. So instrumental activities of daily living, meaning like I'm able to get my own groceries, I'm able to drive my car, I'm able to cook a meal for myself, I'm able to manage my own medications and finances. So loss of that. And then it gets real tough when it's the basic activities of daily living, like I'm able to go to the toilet and go to the bathroom myself, I'm able to dress myself, I'm able to feed myself, I'm able to take care of my own hygiene. When those things fall to the wayside, then it gets really tough for a person. But then also loss of dignity being number 3, and then followed subsequently after that is inadequate pain control or concerns about suffering physically at the end of life. What I hear, and almost like verbatim for my patients, is the ones that I've had patients in hospice, they're sitting in bed, and let's say we have symptoms well under control. They're not in deep pain or deep shortness of breath that's not well controlled, or nausea or delirious. They say to me, "Doctor, what's the point for me to sit here in this bed waiting to die? Or having my family just, coming to visit me every day, and I'm just waiting to die."
Isn't that a mental health issue?
You can't really qualify it as a mental health issue when it's like, when you consider
textbook depression, right? What's the point of living has always been textbook. I am depressed.
If you can clinically assess for depression. However, if a person has a life-limiting or terminal illness, and I'm just going to sort of telescope out and consider life as a whole. In all our experiences, whether you're in school, you're doing exams and trying to get good grades, you go to post-secondary school, same idea. You get a job, you work in that particular field, and those experiences for you are, at least to a degree, finding some sort of purpose, maybe wrongfully, because, and it'll kind of get to the end of it, they're fulfilling nonetheless, and they're a grace and a gift. You have a family, you have kids, you raise kids, you do things in your day-to-day and in your life that are fulfilling for you. It gets real tough when, whether it's because of age in and of itself, or whether it's because of a diagnosis that tells you, hey, you don't got much time left on this earth. And for this next example, I'll use myself just so it doesn't like upset or offend or scare anyone, but this job that I have as a physician, am I going to be able to do this forever? No. Whether it's because of age or a diagnosis that tells me, Sam, you don't got much time left on this earth, I'm not going to be able to do this forever. Hobbies that I have, playing sports, going to the gym, traveling, luxuries that I'm, by the grace of God, able to enjoy in this life, or even the capacity of which I have to serve in my community. Whether it's because of age or a diagnosis, at some point, I'm not going to be physically able to do those things. Now imagine when it gets real tough, when it's, okay, I can't clean my own house by myself, I need help. Or I can't take care of my own laundry. I'm no longer able to drive. For me to get up and go to the bathroom is unsafe, and I need a walker or a cane or somebody to lift me up. And the reality of what happens in this life is, whether it's a job that you have or whether it's this flesh, what it has to offer you is finite. And hearing these answers, these top 3 answers of loss of dignity, loss of being able to do your activities of daily living, or loss of being able to do what's meaningful to you, if you, and what I think is a loss of purpose, if you draw purpose from something that is finite, it will inevitably fail you in the face of death.
So you're about to go.
Me though, sorry, forgive me, because on a spiritual level, we look at things very, very differently.
Yes.
And what is sad is that we forget that this is a time of introspection. This is a time to offer repentance, right? This is a time also where I'm humbled. When I can't dress myself, I can't eat, I can't drive anymore, right? I'm humbled. And that's beautiful because I become dependent on God again, right? So it's as if God is getting me ready, right? To meet him in heaven, right? And to be able to offer that repentance. And now all of a sudden, this opportunity is taken away because you need to die with dignity.
It's not just that, Father.
But that's second death. That's the second death.
Yes.
But it's not even that. You're taking away the opportunity for your children to serve and honor their father and their mother.
Yes.
Like, when you were saying it, I fundamentally just got sad for a second, because what we're doing now is, we used to be, and I say used to, I mean humankind, okay, used to be based on the principles of, you get older, your offspring, your children, those whom you, brought up into the proper principles, they now repay the love and the investment that you put in them by caring for you. Everything Father just said about the spirituality to you is one thing, but it's to everyone else around you to honor my father and my mother who lifted me up at every point in my life. Yeah. Now it's my time to bear that with you, that burden, to care for you. You're taking away that spirituality from me.
Yeah.
The ability for me to repay God and you for what you've done. And there's a beauty in that. That's why I'm saying, who defined that there's no dignity?
So
Paul, I don't get.
I want you to know that we're actually in a state now where, because of the commodity of a dignified death, we have children who are convincing their elderly parents to consider this.
And that's where I got sad, because that's the thought I had. Not convincing, guilting them.
Of course.
That's where I got really sad.
Think
because if this becomes the norm now, whereas before an elderly father looks to his son and he says, you will lift me up and I rely on you, I am humbled. But the son says, this is my duty, my honor, and my love to do this for you. Instead, you're almost guilted by the child to say, like, you're useless, you can't feed yourself, you can't clothe yourself, why are you here? You're just a burden on me. If that person was not going to want to commit suicide, and let's call it what it is, then now I've guilted them into it, because maybe they didn't want that, but what they don't want more than that is to burden me.
So forgive me, I need to say something before you continue. You said that suicide. I genuinely believe, from a spiritual perspective, this is murder. Because I am asking someone to pull the trigger, and the institution is happily saying, done.
Yeah, it's both, though. Yeah. It's both. It's like I'm approving you murdering me, right? So I have a hand in it as well. But my issue here is, we now are telling people that may not want to end their life that maybe this is what's best for everyone around you. Yeah. And if they didn't want to do it, perhaps now they're pushed to out of love for those around them that will be burdened. That's a scary, sad, depressing thought.
I'll share some, like I had a patient last month that I was meeting for the first time, and his reasoning for, he was one who from that first home visit told me, like, oh, he's done his MAID assessments. He said, like, I'm only considering because, like, I don't want to be a burden to my family at the end of life when my circumstances really change. But I mean, one thing I notice in the theme here when we're talking about sacrificing children caring for parents, or a wife who cares for her husband, or husband for a wife, or friend, or whoever they may be, the core of these actions is love. Like, this is, you deny yourself to help somebody else. And truly, like, I think in this role within palliative care, it has shown me my selfishness as a physician, because the one thing I cannot even come a fraction of the way close to being able to replace is love. And when I even have simple moments as a wife who's at the bedside holding the hand of her husband who's dying, I can't replace that with medications. The morphine or opioids that I prescribe, or medications for shortness of breath or nausea, nothing like this will ever come close to a moment like that. And even when a husband is feeding his wife or helping her to the bathroom, there's care and compassion. And what you witness is a history of love in those experiences. Yeah. And the rush towards death takes away the sacrificial love that we are responsible for in each other. Yeah. And that love is a direct reflection of God himself. Yeah. It is wanting to, like, cut it at the cord and limit God's exposure in those particular experiences by saying rush towards death. And something I try to remind patients often, especially in the journey that leads to a death, is they sometimes will get, like, lost in the chaos and the minutia of, like, making decisions on, like, we're adjusting medications, and maybe it's not, it's time for them to go to hospice or be transferred from home to hospice if family really struggle to support their needs at home. It's a lot of decision making and a lot of difficulty on them. But I tell them, like, don't lose sight of what you provide as a family, and don't lose sight of what you provide is immeasurably more important than what and I'm not discrediting nursing staff. They are an incredible backbone to this, but even my nursing staff can't provide the same love and support as a wife to a husband, or a son or daughter to a parent, or a close friend. And when I look at the opposite, like, I've had patient experiences where they're estranged from their family. The deep anger, resentment, lack of forgiveness and reconciliation for many years. And I remember this one instance with a gentleman, and I go into his room, and it's like it's a hollowing experience just being in that room. It feels like at a moment, like he's ready to be angry. He's so like upset, and he had, I think, a niece that was visiting him, and she's the one person that came to visit him. But close friends, family, all not there. And it makes death a lot more difficult. Like physical symptoms get worse, and I truly believe this, in the absence of love, in the absence of like the compassion that we need to show to each other. And even when I have like patients who get delirious, and like delirium is one of those things at the end of life that's quite prevalent, like upwards of 80% experience what we call an end of life delirium, which is just as an aside, like delirium is this fluctuating state of confusion, and that confusion can feed into physical symptoms. But so often are we asking family to come to the patient's room or be there when they're delirious, because that familiar person, that familiar voice, that familiar touch of the hand is comforting, and it helps them to not feel scared, because truly they do feel scared in those moments.
Can I contrast that with a pastoral situation that I had to deal with? I have this young woman who comes to me for spiritual counsel, and on her journey in deepening her faith, there was a period where she was part of the nursing staff that helped administer these forms of medications that were lethal. And she described one pivotal moment that she witnessed that completely set her off and made her question whether or not she could ever do this again. The patient was explained that if you do accept this, and now that you've already been like qualified for it, the process is going to be the 3 medications, and then ultimately, right after the last one, within a few moments, you're pretty much gone. And they brought the family in, and the family was going to be there for those final moments. And the patient said, "Yep, I completely understand. I'm good. We're ready to go." They administered first and second medication, and then the nurse is describing and saying, as soon as I gave the 3rd medication, the family broke out into tears instantaneously, and the patient has enough time to be able to respond and say, "Don't cry, like we still have a little bit of time." And so the nurse said, no, you don't. And the last words that were spoken by the person is like, what do you mean? I'm not ready. The person understood, you have a few moments. He interpreted that as whatever. And so there's this moment of panic, and I want you to like put that next to the reality that you're describing. A hand of a person who loves you and who's helping, escorting you into the arms of God, versus you're dying with this idea of panic, and I didn't have a chance to make peace. I didn't have it. Regardless of whether or not we say the patient must understand and they sign off, there is so much ambiguity as to whether or not we have actually equipped the patient to know that they are accepting upon themselves a certain level of death that is... It is absolutely devastating to see these situations happen.
This entire conversation reminds me of this saying that says we used to use things and love people, right? Now we love things and use people. And now that people have become useless, well, that's just the part that I'm adding, there's no need for them anymore, right? So like going back to what Paul was saying earlier, and to Abuna's story, that like and to you, Sam, when you have, you know, a loving relationship with a family and that comfort that is there, there's nothing more meaningful than that. There's nothing that brings more healing than that, right? So that's that concept of, like, you know, like Paul was saying earlier, something that really struck me, like, you know, when a son tells his father, like, you're useless, what are you doing here? No, you need to love him, you need to serve him.
And I hope it's okay with, I mean, I have a couple of friends this year who went through really tough times with a couple of parents, actually. Okay, both parents. Okay, if this person were struggling physically, you know, an illness, and it was a lot. Okay, and I saw the burden on the person who was ill firsthand through very close friends of mine, but I also saw the honor that those people did in supporting, in loving, in carrying their parents. And I told them several times, and I don't think I told them enough, but I told them there's no book I could have read or Sunday school lesson or sermon, forgive me fathers, I hope that's okay, that could have taught me honor your father and your mother as much as what I saw you do in the last year to 2 years.
Well said.
The spiritual lessons that we all, anyone that was close to them, learned from watching, not just the cross that they carried faithfully and joyfully with honor, not just the lesson to everyone around them. Like, look at all the spiritual wealth that was created through a time where the world says, you're useless, you're in bed, you're a piece of meat at this point, inject and end it here. As opposed to honor your father and your mother, as opposed to carry your cross joyfully. And then when they do pass, the faithfulness to, one, know where they're going and rejoice in that, but also to mourn, right? Not say, oh, good riddance, it was tough on me. No, to mourn and say, no, I did that joyfully, honoring you joyfully, right? Like, look at all the benefit, the spiritual benefit. Those people, that's the calling card to the kingdom of heaven. That's their entrance right through the gates, right? But I feel like as the world has fallen away from God, we have, and forgive me for the word, screwed up everything. Everything has been skewed to the point where we can't even agree on death and life. Father said it. Like, we now as a society, we cannot agree about the sanctity of an unborn child, that they're still a child, and we can't agree on honoring the last moments of someone's life.
You know, to your point, you know, I just remember the story with my grandma. When I was young back in Egypt, I was maybe 5-6 years old, right? Just talking about that covenantal love between like family members, right? And I was sick and I had a fever. And she was there next to me. And she said this one sentence that until now I remember as if it was yesterday. She just said, I wish it was me and not you. Just being next to me. And I was a child. I don't even know how I remember this. The only reason why I remember this is because I heard those words and I was like, wow, she really cares. And that meant a lot. So much. And my grandma told me a billion things. I don't remember any of them.
But this one.
Except that one.
This one, yeah.
Right? So it's very meaningful.
Yeah.
So now, just for, I think our biases are clear. Like, I don't know. Should we at any point maybe define that we, like, this is wrong as per the church, or do you think people got the point?
I really hope the audience
like,
got the point.
I feel like we've been passionate enough but just in case it's not right, where we don't agree with it. Sorry, I got to poke some sort of, lightness into the situation. But two things now that you have to help us with. Pulling the plug. And the other one was, sorry, here I'm losing myself, palliative sedation. Okay. And then I have a third one for you. Just remind me of it. All right. And it's the difference between not taking medication in the first place versus, pulling the plug. All right. So start with the first two first, and we'll go there.
So pulling the plug, or so often that's a phrase used in a circumstance when a patient is in a coma because they cannot support their own breathing. So they're like intubated, they're on a machine and on a ventilator. They're maybe getting medications to sort of help try to keep the heart pumping as well. And they're usually in a, acute care setting in a hospital or ICU. And the thing about this pulling the plug is that we have to remember that in those circumstances, like let's say it was a bad car accident where somebody has a brain bleed, and often brain death is really what we're trying to define here. And there's ways to clinically assess, like examine the patient to confirm brain death, because the brain is responsible for the body's function. Our respiratory system, our breathing is driven by an automatic process that happens in the brain. And I don't have to like actively think to myself, okay, Sam, take a breath. Okay, take a breath now. No, that's automatic. And there are ways to like assess this. So if a patient in that circumstance, they're intubated, they're not awake, and that there is a stage where we have to like consider, do we remove life support because this person cannot sustain their life on their own anymore? When you assess for brain death, you look for things like, do the pupils of the eyes of the patient constrict when you shine a light in their eyes? It's an automatic reflex. It's innate. It should happen. If there's any sort of damage to the mind and the brain and the cerebellum in particular, and the brainstem, that if this is not happening, there's parts of the brain that are irreversibly damaged at that point. And I think, and I'll throw it to the priest as well in case I say, hopefully I don't say anything wrong, but like mind and soul are uniquely intertwined. You cannot have one existing without the other, and God uniquely designed us this way. So when you assess for brain death and you confirm like, hey, there are signs here that this brain is no longer functioning, then you kind of have to have a real discussion with families. In some areas, actually, they have some unique like scans that can be done, like certain specialized CT scans that could be done to see if there's any signs of brain activity. But clinically, you can diagnose this based on the patient being in a coma, signs of brain death that you can assess clinically, reflexes, eye response, and pulling the plug means I'm removing this life support, and then the patient will naturally pass away. The heart will stop eventually without machines that are essentially keeping them alive. Like nobody came out of the womb with like being intubated. God, we're able to be self-sufficient and function and live, and having that life is an automatic process that's ingrained in us. So if you are only living on machines that are artificially keeping you alive, this is not what life is. And so that's different to like medical assistance in dying even, or palliative care.
So tell me, what if there is no like the brain is alive,
yeah,
but they do need those machines to stay alive. So there is brain activity, but you're still on these machines.
Yeah.
Is pulling the plug there, and maybe this is more of like a question for Faz, I don't know, but spiritually, is this similar to MAID, or is this just allowing nature, like God, to do his thing?
So pastorally, the church, the Orthodox Church specifically, the hard line really is brain death, because if the brain is now in a state where we consider the person to be brain dead, you can keep them in existence forever because of the use of technology today. You can keep lungs pumping, you can keep heart beating, but the person is no longer there. The church truly does believe at the level of anthropology that the soul is no longer there if the person is brain dead. Now, where it gets very complicated and it's very nuanced, and oftentimes it requires a tremendous amount of discernment, is what you do with specific situations where the person is still fully there. It's fully there, fully alive, but requires the intervention of technology and life support. In those cases, it would be useless for us to be able to even consider the idea of pulling the plug, because there is still hope here for the restoration of health. There is no reason to consider that this person is dead. So as long as there is something that can be healed and life can be restored and health can be worked towards, then the church encourages that we continue to remain hopeful. And this goes back to what you were saying. Continue to remain hopeful, to invoke God's name, and to do everything that's in our power. MAID in this situation is literally saying it doesn't matter whether there's hope or not, doesn't matter whether there's technology, for the sake of comfort and convenience. And we like to talk about quality of life when considering MAID, especially here in Canada. What we're really saying is, have you considered killing the person? Right? That's not the same as we already think the person is gone because of brain deadness.
But Father, so now a follow-up question that people would ask is, why not allow the natural way that God allowed to take that person? This is their time. If they don't want to use a machine, and the machine is what's keeping them alive, at this point, that's it, right?
So pastorally, and Father, feel free to chime in at any point. Pastorally, especially when the person is in a dire situation where they are already terminally ill, we know that there is no cure. Scientifically and medically, that the resources that we have will not be able to restore this person to health. Okay? This is where there is the gift of palliative care. And the gift of palliative care is the means by which the church says pastorally, let's now begin the process of preparing your loved one to meet their Savior. And part of that is surrounding them with family, making sure the church is involved to receive confession, comfort them, prepare them, help them reconcile if they need, make them feel absolutely ready to meet the Savior. And along that is we use medical professionals like Sam to be able to create a certain level of comfort so that they're not overtaken by the suffering that the body is physically enduring. So palliative care in those situations can definitely be considered. But there are times where people want to consider that very prematurely. We've seen situations where there's really no need. You can undergo, yes, it's going to be a very difficult, it's a very heavy cross that you have to endure. But we encourage that person, especially when they have responsibilities. A young mom, a young dad who might have to undergo some treatment that is very difficult. Don't quickly jump to palliative. Don't quickly choose comfort when there's an opportunity to carry a cross and be a person who considers those that you have relationships with, as well as your own salvation in the process. So the pastoral situation of the church can sometimes get very difficult to navigate.
Yeah, I
think it's important to also emphasize that the opposite is also true. When sometimes we have people that are really, really holding on their parents when they're done.
Yeah.
Right. So death is a process, and it's clear that the person, like, there's no going back to life, and they just want to hold on them, to them so much for so long. But you have to remember that you are a Christian. You believe this is just a departure. You want this person to go to their real home and meet their God. So we also have to avoid that other extreme.
And just for clarity, and if someone has this question, DNR, like do not resuscitate.
That's a bit different. The term is, I know it's still utilized in some areas, but it's getting to be a little bit archaic because it's a very black and white term. It goes into the conversation of around advanced care planning, and
can you actually define what DNR is for a person?
So the word actually, or the acronym means do not resuscitate, and
which means,
like, to not do CPR, compressions, intubating the patient, shocking the patient. And it's always, when I have these conversations with patients, it has to be in the context of where their health is at right now. Somebody who's healthy, young, and can go through these measures, yes, okay, by all means, we'll talk about this, and probably is a full code at that stage. But when for example, I have patients that are living with cancer and multiple chronic illnesses, where we have to talk about, are these measures, which truly, like, it's not as simple as just what we see on TV. You shock the person a couple of times and they come back to life. Compressions are an aggressive thing, beyond the fact that they will break your ribs when they're doing compressions, and intubating the patient also can be aggressive. But I always tell the patient what your life looks like right now, and in the chance that we can bring a person back to life, and just so people understand the figures, the numbers are talking, especially when you're living with a chronic illness and illnesses like cancer, we're talking single digit percentages. If you're like present in the hospital at the time of when your heart stops and you need resuscitation, we're talking single digit percentages. And if in the off chance you are able to be brought back to life, knowing the chances are low, your life before and after is going to look drastically different. You might not be able to walk. You might not, essentially, if your heart's not pumping and blood is not flowing into your brain, that could cause essentially damage to the brain that leaves you with a stroke. One side of the body might not work. And there is a real conversation about the reality of when measures like this are no longer appropriate for the person, given their circumstances of where their health is at that stage. So in Alberta, at least, and I think in many provinces in Canada, we see like a ladder or a tiered approach of how a person might want measures like this or not want measures like this. And in Alberta, it's called a goals of care document, where if you could have, let's say, I won't go into all the specifics. Some patients might want to be a full code. They might only want to go to ICU and not have compressions and intubation. They might only want to go to hospital to treat what is reversible and manage me in the hospital. Then it comes to a point where a person says, hey, like, going to the hospital is not like giving me quality of life. I'm suffering and this is not actually benefiting me. And I no longer want to go to the hospital to get treatments like treating an infection. I'd rather be just managed at home, try to manage the infection at home. And then we get into the realm of often when patients are ready to go to a place like hospice, where our focus is comfort care and comfort measures. And typically when they're ready for hospice, we're at that stage of comfort and supportive measures.
Okay. Now we can go to the spiritual part if you'd like to. I'd like to. Can we? I know we've dealt with suffering before, and we don't want to go through all suffering, but the beauty of suffering, the spiritual purpose of suffering. Maybe if the priests can start us off, and then Sam, what you've seen in real life, that would be really something. Because I feel like this whole "it's undignified to suffer" is something that we've gotten completely wrong.
Yeah. Absolutely.
So let's start there.
There is an understanding, especially within Orthodoxy, that suffering can be something that is transformative. And when I say transformative, I'm not just talking about, to go back to Father's example, it's not just the whole right-hand thief situation, right? Where you're now filled with conviction, you realize you're finite, and then suddenly you say, forgive me, Lord. That is definitely an important aspect to it. There's an additional aspect to this, where suffering is one of the means by which you get to participate in what our Lord Jesus Christ himself endured for the sake of glory. St. Paul talks about how it is that if I suffer with him, I'm also glorified with him. So when we allow the Lord to be able to when we allow God to be able to use suffering as a means by which I am purified, my heart is consecrated, and I can offer that suffering not only to him, but even to those around me. You were just giving a beautiful example of how it is that when you saw your friends and family go through the process of carrying one who suffers, you not only saw them become Christ-like, you saw the one who is suffering to be Christ-like, the people who carried him to be Christ-like, and you were then inspired yourself to be Christ-like. I promise you, Paul, we have seen situations where even medical staff who have nothing to do with the church have pulled us aside as clergy and told us, that gentleman who just passed away, the way that you guys as a community have surrounded him, loved him, the family coming in and out, you showing up to bring communion, I can only pray that my final moments are filled with that level of love and honor.
Are as dignified as them.
Yeah.
Truly, right? Truly.
It is.
Suffering is the vehicle by which the Lord is capable of communicating that beauty.
Compassion.
We need to stop acting as if, for whatever reason, and forgive me, and this is not towards you and all the incredible medical staff who do an incredible job, but somehow within the system, the institution of what it looks like to offer medical assistance now, it has all become about managing suffering and really no longer the restoration of life. Everything is reactive. There's something there that's unfortunate. Sacredness of life is completely set aside. And now it's all about how do I make you comfortable. And that's a very terrifying thing because we're not allowing suffering to be transformative.
Father Gabriel, suffering. What does that mean to you from what you've seen pastorally?
I mean, Father Anthony, I think summarized it very well. The only thing I'll say is that suffering is inevitable. Suffering in our current state is a must. To avoid it would only lead to our destruction. Or we are filled with God, or we are filled with ourselves, right? And so there's this saying again that says, or you have God in your heart, right? So you crucify yourself to have God enthroned in your heart, or you sit yourself on the throne. So me carrying the cross leads to God being enthroned in my heart. And this is a reality. And the smallest or the easiest type of suffering is just to follow the commandments. Right? So this is the basic, right? But then like the monks and the nuns, and Christians that seek sainthood, they take it to a different level. When one of the Desert Fathers says this quote that is beautiful, he says, to avoid anything that brings you down from the cross. So the implication is that you are already crucified, and do whatever you need to do to remain there, because this is what makes God enthroned in your heart. So, and I mentioned a few stories earlier on how that leads you to be humbled, right? And by being humbled, you empty yourself from yourself. That idea of kenosis in Philippians 2, again, following in the footsteps of Christ, and then Christ fills you. So it's a gift. Suffering is a gift in this life. It's not God's design for humanity originally. It is a reality in our current state, and it's a gift that we need for our own salvation. So, for myself and for everyone, my response or my advice is don't avoid it, but seek it. And I know it's difficult to say. So I'm the first one that will say, God, enough. I had enough of this, right? Remove this from me, right? And then I come back to my senses and say, you know what, thank you. Because, I thank you for that suffering, because without suffering, I don't know how my life would be, how far away I would be from you, So I think we need to embrace suffering to a certain degree.
Forgive me, I'm just going to chime in because I'm not the smart or spiritual one in the room amongst these gentlemen and the two fathers. I shouldn't say gentlemen, sorry, forgive me. I don't know if that's disrespectful.
Are we not gentlemen?
You're yeah, okay, whatever. That's not the point. I think but something I was always told, and I want to just mention it, is we suffer, and the world tells us we must suffer for anything that we want to produce or to come out with as a treasure, right? So we suffer in school in order to get good grades. We have to toil in order to reap the harvest that gives us our food. We have to suffer and work hard if we want to be physically fit. Nothing comes without a suffering or pain. And I would appeal to those who don't, understand everything that's happening. The most simplistic way to look at this is even the suffering of the final moments of death and the dying of the body. This is the greatest treasure for eternal life. And I'd like to pay homage to the late Father Fanous, who's one of our shepherds. He used to go to someone who knows they have cancer, especially if they're terminally ill, and you'd say, congratulations, in Arabic, Mabruk. You have now gotten the gift of heaven, the disease of heaven. And he would call cancer the disease of heaven. And in his mind, and he believed this is the greatest gift you can have, because not only is God telling you when your time is about to come, right, to get prepared, but he's also telling you, if you do this faithfully, it's done. It's locked in. Your eternal salvation is here. And he would smile and say Mabruk, which is congratulations in Arabic. And then sometimes you would say Ya Bakhtak, which is along the lines of like, I'm jealous of you, lucky you, and people would think like this is lunacy, but this is spirituality. So I just wanted to chime in with that.
He would even say when someone would have a problem, would go through a big problem, he would tell him, pray to God that he may give me your problem. It's similar to what my grandma was saying, funny enough, right?
It's that generation. They get it. And
it changes them, Well, I think about it sometimes, like how bad of a priest I am, especially when I compare myself to the Father Lucas Hidaros, like all of these giants,
the ones that were imprisoned and they were smiling and singing in the prisons because they were imprisoned for their faith.
Like that's exactly what I wanted to talk about. So these people, they go into prison, their reflex is to kiss the floor. So they were put in prison because they were popular priests, right? And the government at that point in a different country put them into prison. And the reflex is like to kiss the floor, open Philippians, and read how St. Paul was joyful when he was in prison.
That's right.
Which is like mind-blowing. But then the reality hits and they suffer. And they suffer and they suffer while they're in prison. But that suffering is what made them those spiritual giants. And you look at them and like, wow.
As a link, Father Bishoy Kamel also used to go into the room in the hospital of someone who's terminally ill, take off his shoes, and they would ask him, why are you doing this, Father? And he'd be like, I'm about to enter the altar. And he would kneel before the bed and kiss the bed and kiss the patient or whoever he was, and he would say, because this is where the sacrifice is, and this is where the Lord is, and I am witnessing this holy ground. These are the real, that's real meaning. That's the dignity of it, not undignified.
For those that don't actually fully understand that, is because in the Coptic ritual, we remove our shoes before partaking of the Eucharist.
Sorry,
right?
So
like Moses removed the sandals when he approached the burning bush. This is how a ritual goes. So when he removes his shoes before approaching the bed, is because it's like Christ, you know, that's what he's saying. It's as if I'm on the altar.
Do you want me to, if it's okay,
please, now. Yes, it's your turn. Sorry.
No. I was going to share some like patient interactions or quotes that I've had.
Please.
So I was caring for a gentleman last month in hospice, and this is what he said to me. He said, cancer gave me several gifts. How can I possibly be mad? It helped heal the relationships in my family. So he saw like he's a very, very good man, very, very smart, but he saw the beauty of his suffering in him. I'll share another story that it sticks out so vividly. And this is a gentleman I cared for in hospice kind of towards the tail end of last year. And then God rest his soul, he died in early January. This man was, God used him in a very special way to even send a message to somebody as sinful as myself. There was a day that I was going to hospice to do my rounds, and I was under a lot of stress. It was before I was going to propose to my now fiance, and like the chaos of all the planning that comes with that, and like the emails and the flood of like tasks, and I was just like super anxious about a bunch of stuff. Now I had to, of course, go to hospice, and I've got like, you know, a dozen patients and families who are dying, or patients that are dying and their families to kind of try to guide. And so this gentleman, and I met him throughout that week, he had this, we talked about faith, we talked about spirituality. He came from a Christian background. He had this beautiful, like, Celtic looking Bible, like the cross is a bit Celtic. And when I got into the room and I'm going to go see him, and he asked me how I'm doing that day. And I'm like, oh, I'm just keeping my head afloat. And he says, let me lend you an oar, like as if like I'm helping me in the boat. He's like, let me lend you an oar. And it's just for reference, like his circumstances were, he's a man in his early 40s. He's very successful in his career as a veterinarian. He's married, he has 3 kids, and he's dying of lung cancer, and, you know, doesn't have risk factors to get a particular lung cancer, but here he has lung cancer. And he's in hospice. He, you know, who knows how much time he had left at that particular point, but he says to me, let me lend you an oar. And the verse that he opens up with, and he, before we even got into anything related to his health, he says, I was reading the Bible yesterday, and I was reading the book of Matthew, chapter 11, verse 28, which is the verse where Christ says, come to me, all you who labor and are heavy laden, and I will give you rest. Take my yoke upon you and learn from me, for I am gentle and lowly in heart, and you will find rest for your soul. So in that moment of my own worries and anxiety and life and chaos, God used this man who's dying to send me a message and a verse that, like, this is exactly what I needed to hear at this point. This is exactly for me. Like, I need to lean on him. It's not about me trying to figure out everything. It's Christ who's going to help me carry the cross or crosses that I'm failing to carry on my own. And that's really like, in alluding to like the beauty of suffering, you don't suffer alone. And like even in like when like we said earlier, a wife or a daughter or son who's helping a parent and they're helping carry their cross, like obviously God brought this person to their life to help them in these moments and help shelter that cross. And you get to witness very clearly who Christ is to you personally when you have to shelter a cross. But he's a gentleman like I got to know quite well, and the peacefulness that he had, the compassion that he had, the spirit that he had, and how much love he showed his wife and his children before he died. I am witnessing Christ through this gentleman, and this is what these types of moments offer you. They offer an individual. It's that it's not just a suffering that's liberating for the person carrying the cross. It is liberating for those that get to be a witness to it as well, and that's in and of itself a gift. And what, you know, to get back to our main topic, what medical assistance in dying does is it tries to close the curtain on that window of opportunity to witness God truly in the life of the person or within your own life.
And it robs you.
It robs you of it.
Mm-hmm. So then let me take you to our final question. Where do we go from here? What do we do? What's the next step?
Yeah. As
clergy, as lay people, you as a physician, viewers, like, what do we do?
Well, I think that when knowing that death is a inevitability in the life of each person, and having those conversations, like I said earlier, being able to engage in this freely and not being afraid. And like, you know, culturally, there's a term that we use. We say badishar. Mm-hmm. It's like something like we avoid. We just kind of leave it. Mm-hmm. But it's okay to have these conversations and talk about something important, and from a sense of preparedness, spiritually, of course, but also like physical preparedness and a responsibility to God above to understand what our responsibility is for this physical body that He's given us. understanding palliative care, I think, is important, that we don't have to think that death is this scary thing and it's going to be inevitable suffering. Therefore, I will utilize something like MAID when we consider the amazing options that we do have in palliative care. And something we should still touch on is like palliative sedation.
Sorry, I forgot. Yeah, we were supposed to. Yeah, but continue with your thought. And then
yes, yeah. It's I think for us to know that, like, we can alleviate physical suffering, we can support spiritual suffering, we can support psychological suffering, and allow a person a dignified death that truly is dignified and aligns with our Lord and God above. So people need to just know that there are means to this, practically speaking, so you're not left thinking, the world is telling me rush towards death. Nobody's talked about the other options that are available, and so hey, like let's talk about those things, and also be able to prepare ourselves spiritually for something. And also, I think an important truth for us as Christians to align by is our physical death is no longer equal to an eternal death because of what Christ did for us on the cross. And so when we focus on the cross, whether it's you're carrying it or you're viewing it as an icon and seeing what Christ did for you, you realize that we are saved in a beautiful way and in a sacrificial way when he gave himself as ransom for all of us. And that is love in and of itself, to deny yourself and to die for somebody else. That's self-denial and love, truly.
Father, what do we do?
I think there's a really big, important aspect to all of this, that we as Christians, we must absolutely, we got to have conversations where we encourage each other to stop being afraid of death. When you view death as the end, then you are denying the message of the gospel. Christ did not come and was incarnate and emptied himself and underwent betrayal and suffering on the cross and death and burial and resurrection and ascension so that you and I could be afraid of death. I mean, you were just referencing this before. How do we encourage a woman who is pregnant and she's in those trimesters that are very difficult and she's got nausea and she's suffering? What do we tell her? Endure this for a while. Why? Because the joy is right around the corner. What do we tell students who kill their social life and they study 18 hours a day and they give themselves over to residency and they're a slave to... And what do we tell them? It'll be worth it in the end. Short-term pain, long-term gain. We say this to Olympians who are athletes. Go ahead and struggle and be an athlete and be ascetic and be very disciplined, because it'll all be worth it once you compete and win. The same thing applies to our lives. Everything that we do now, even the endurance of suffering, is all with the hope of knowing that death is nothing more than a passageway. I pass through it now. It's not my end state. It's a door that swings open and I go through it and now I have access to eternal life. If I can understand that and know that it's real, then the idea of accelerating it with the intention of me remaining in that state is absolutely absurd. Because Christ is the way, the truth, and the life. By no means should we ever suggest as Christians that we will try to anticipate or facilitate or accelerate the idea of remaining in death. God forbid that we should do that.
The only thing I'll add is God is almighty. He is in control. Let's not play the game of acting as if we are God.
That's a terrible game to play.
It's something definitely that we shouldn't be pursuing. Let him do his work. Let us not intervene. Let us enjoy life as it is, and in preparation to meeting him for eternal life.
Amen.
Doc, did you have any last things you had on your mind? I forgot a few things. Is there anything left out there that you wanted to mention?
When we talk about death and sort of something I think about often is like, we have to consider like where this thing even came from, like physical death, that God did not make us in his image saying, okay, you're going to be born and you're guaranteed. That wasn't, we read in Genesis, like this is not what, there's no mention of death. Death is a consequence of sin. So if you are rushing towards death, you're rushing towards something whose core source is sin, which means if I'm using my own will and taking God out of the equation, which is essentially what something like medical assistance in dying does, it means I'm rushing towards something whose core is rooted in sin. And rushing towards Christ, or knowing that he is the life, is, what necessary for us.
And trusting in his will, right?
Amen.
Amen.
Mm-hmm.
On that note, thank you so much for joining us. Fathers, thank you. This was very enjoyable, even though it was very dark. It was still very enlightening. Thank you all for joining us. We'll see you next time.